In just a moment, see some familiar names. Be great to meet people here.
Okay, well, it's 3 o'clock. We'll go ahead and just get started. I just wanted to introduce myself and the doctors that are going to be leading us through the session. My name's Amber Rogers, and I'm with Mountain Pacific Quality Health. I did want to let you know that we don't have any disclosures. We don't have any conflicts of interest for our physicians. They are co-owners of Frontier Psychiatry, but we're not selling you services during this, so you don't have to worry about that. There also are continuing nursing education credits that are available. To get those credits, you do need to fill out the evaluation at the end of the session. And then I will send those out. It is worth an hour of continuing education credits. CMEs are going to be available. We are just still in process of that. So I just wanted to disclose those few things, and I am going to turn it over to our fearless leaders, Dr. Bob Seiss and Eric Arzubi. So take it away, guys.
Great. Thank you so much. So again, I'm Dr. Eric Arzubi. I'm board certified in child psychiatry as well as general psychiatry. And what I'd like to do is we'll start off with introductions. And even though, well, today we might excuse some of you because you didn't dress appropriately, but in general, we're going to ask that you turn your camera on to be part of this and make it as engaging and interactive as possible, because it's a little weird staring at like black screens all the time. So that would be awesome. And so first, I'd like to introduce the hub team, and then we'll go and get everybody else introduced as well. Bob, if you please.
Yeah, hi, Dr. Bob Seiss. I'm an addiction and general psychiatrist. Really thrilled to join you all as we start off this ECHO clinic with our first formal session starting on the 21st today. We're going to talk through what ECHO is and give some background on substance use disorders. Welcome all.
Thank you. Next, let's see. So Amber, you introduce yourself, right? And then who else is there from Mount Pacific? Jessica?
Hi, I'm Jessica Leister-Fry from Mountain Pacific, and I'm just helping with the team to help monitor the chats, and any IT support you guys need, we can help you with that.
Wonderful. Thank you so much. And then who else is on from Mountain Pacific? We have, let's see.
Hello, this is Sharon Phelps. I am with Mountain Pacific helping Amber and Jessica and the team if there's any background needs that they need or to cover for them when they're unavailable. Welcome to the 3D Echo. Thanks for coming today.
Thanks, Sharon. Anybody else from Mount Pacific that I'm missing? I apologize in advance. Mary, there you are. Yes.
Mary's here. Mary and Mary.
Yeah, but you got to say who you are, what you do.
I'm Mary Erickson. I'm program director at Mountain Pacific, and I work on the CMS task order. So I'm here to observe and learn and see what else we can do. Mary Argonis, you're up.
Hi, I'm Mary Argonis. I'm IT support for this 3D Echo. I'm project support for Mountain Pacific. Thank you.
Thank you. Let's see. Sarah, do you want to introduce yourself from Frontier Psychiatry?
Yes. Hi, I'm Sarah Porterosin. I'm the Director of Operations with Frontier Psychiatry, and I will be assisting with this ECHO clinic as well. So welcome.
Thank you. And then Jessica?
Hi, I'm Jessica. I'm the Operations Manager at Frontier Psychiatry, and I'm also assisting with the clinic.
Thank you. So now come the more important introductions, all the folks out in 3D Echo land. And so what I'll do is I'll go and thank you everyone for turning on your cameras. That feels much better. And what we'll do is just go through each person, and the introductions today will probably be a little bit more lengthy than you're used to. And then what then will happen in the future, because by then we'll kind of be a cohort who knows each other and be learning together. But I just want to make sure everybody knows who's here and get to know each other. Again, what we're trying to do is build a learning community. So Dawn Marie.
Hi, my name is Dawn Marie Thacker, and I work with the Wyoming Long-Term Care Ombudsman Program.
Thank you. Next, Carol Savage. Oh, Carol, you're still muted, sorry. So there you go.
Okay. Hi, I'm Carol Savage, Savage Consulting, a registered nurse, legal nurse consultant, certified dementia practitioner. I specialize in elder care and community health services, care management in the community. I've done a barrage of nursing from mental health to dementia care, and my goal is to attain an ongoing knowledge to keep a better practice in my field. So that's what I do. I'm in Kalispell.
Great, thanks, Carol. Agnes White.
Hi, good morning. I'm Agnes White. I work with Mountain Pacific and I'm an account manager, and I'm out here on Guam. That's why I said good morning.
Welcome from Guam. Thank you.
Thank you very much.
Dawn Bell.
Hey, yes, my name's Dawn Bell. I'm with Project Hope. It's an naloxone distribution program with the state of Alaska. I'm in Anchorage. I'm also a paramedic and here to observe.
Awesome, thank you. And again, I just, like I said, we're trying to build a learning community. So the idea is, and we'll go over this some more, is that everybody's going to learn from each other. We're helping facilitate, but you know, I'm just imagining the diversity of experiences and knowledge that people bring to the table. Everybody's going to be teaching everyone. So just be prepared for that. Hope Kratz. Hi.
Hope Kratz. I am the clinical director of Monida Healthcare Network, and we are building a clinically integrated network throughout the state of Montana. So I'm excited to be here. And Dr. Azubi and Dr. Saiz, it's good to see you both.
Likewise, Hope. Let's see. Oh, let's see. Reza here from Frontier Psychiatry on my phone today. Neuropsychiatry with special interest in dementia and hang on. What is it? And neurodegeneration. Yes, he is. Right, and he's some of you may have attended some of his presentations, and really Reza's work and the collaboration with Mount Pacific is what inspired us to kind of launch a Project Echo. So glad Reza could join. Tamara Knotts.
Hi, thanks for putting this together. I'm really happy to be here. I'm Tamara Knotts. I work for the Montana Primary Care Association as their IBH director, and have long been involved with on both the treatment side and administrative side, program implementation, training for substance use disorders, medication assisted treatment, co-occurring disorders. So really happy to be here.
Thank you, Tamara, for joining. Let's see, next, Kyla Newland.
Hi, everybody. I'm Kyla Newland. I'm also from Mountain Pacific Quality Health, and I'm working to support some of the community coalitions in the state that are addressing substance use disorder in their communities, as well as behavioral health issues and opioid use disorder. And I'm glad to be here. Thank you.
Thank you for joining. Stephanie.
Hi, I'm Stephanie, and I am the Prevention and Harm Reduction Program Director at Open Aid Alliance. And we are a harm reduction based nonprofit here in Missoula.
Thanks for joining. Thank you. Next is, hang on, let's see, I just lost order. Gosh, Dorothy. I don't think we've had Dorothy introduce herself yet.
Hi, I'm Dorothy Kinley. I work for Providence, Alaska Transitional Care, and also for Providence Extended Care, dealing with the geriatric population. But I also work for the Alaska Department of Corrections, and we see a whole lot of substance use disorder in that population, as well as geriatrics. So I'm glad to see this.
Great, thank you very much. Let's see, Maria.
Hi, it's great to be here. I teach full-time undergraduate nursing at Carroll College, and then I also work as a hospitalist nurse practitioner here in Helena. And I just do that locums, but I think anytime I'm seeing patients, it's always good to know additional information about substance use. I also just completed my MAT training to hopefully look at that in the future, and I'm completing my family nurse practitioner, so I know that this information will be able to help me in the future with primary care as well. So thanks for having this.
Of course, thanks for joining. And then the folks who are camera shy, let's see, there's Jennifer, Queen. Sorry, I'm gonna butcher some of these things. And if you're on the phone, it's *6 to unmute. Go ahead, Jennifer.
Yeah, hi, my name is Jennifer Quinn, and I actually used to work at the Flathead Community Health Center in Kalispell. And through that agency, I worked with MPCA to obtain non-prescribing waiver training. And I'm a nurse, so I ran the MAP program until I left. And now I'm at KRMC in Kalispell at the hospital doing complex care. And our patients that we work with are what a lot of people refer to as super utilizers. So we call them multi-visit patients. And so there is criteria for our program that they have to meet and in order to work with us. And we try to get them not just their medical needs met, but obviously their social determinants of health greatly impact their personal health. And so we try to do both of those in service with community-based organizations throughout the Flathead.
Great. Thank you so much.
Yeah.
Next, Agnes White. Oh, wait, no, I think Agnes, we already,
You
okay.
did
Yeah.
me already.
See, yeah, you turned the camera off. You threw me off.
Sorry.
No, that's okay. I'm easily thrown off. Maynette Wong.
Hi, yes, I'm with Mountain Pacific Quality Health also as project support. I help Mary Argonis to help facilitate the webinars that we host.
Wonderful, thank you. Next, Marabella.
Yes, I'm from Mountain Pacific also, and we work out of the Hawaii office here in Honolulu, and we're happy to be part of the 3D Echo.
Great, thank you. Let's see, I think I got, let's see, Julie Cooper. Or not. And then there's C. Allison by phone. *6 to unmute. Nope. Just kidding. Okay.
Oh,
yeah, there you are.
Does it work now?
Yeah.
Okay. My name's Charlie Allison. I'm with Rosewood Healthcare Center in Forsyth, Montana. I work as a patient care coordinator with our behavioral health and collaborative programs, along with chronic care coordination and discharge planning at that hospital as well.
Fantastic. Thank you so much for joining. So, and again, I apologize today, the introductions are a little bit long. It's our first time getting together. So thanks everyone for your patience. What we'll do now, if you're not speaking, please just please mute yourself. And then, when you want to talk, please go ahead and unmute yourself and just state your name and where you're from again. Just let us know who you're talking to, remind us. What I'm going to do is I'm going to share my screen. Let me see, where'd I go? Where am I here? Okay. All right. Bob, can you see the title slide?
Yes.
Okay, great. Awesome. Okay, so here we go. So again, today we're going to be doing an introduction to the ECHO model. The ECHO model, as some of you might know, have heard of, again, started in New Mexico in the early 2000s, started initially by a hepatologist treating liver disease, very frustrated with the fact that his patients had to travel for hours upon hours to get the help they needed. So he started this program where it's a hub and spoke arrangement. That the hub, there you have facilitators and some content experts communicating with the spokes around the region who are the local experts, and then working together on discussing cases and learning about clinical content together. And research has shown if you're able to get engage folks in very rural, remote areas in Project ECHO, you can actually improve outcomes as you disseminate knowledge and make it more widespread. So again, our goal with this particular clinic is we're going to be launching several content-based clinics, but the one that we're launching here, that's going to be led by Dr. Seiss, will be on addiction medicine. We talked about our disclosures. Again, Bob and I on Frontier Psychiatry, we are going to avoid to sell products from Frontier Psychiatry. This web-based clinic is worth 1 credit hours of continuing nursing education, and at the end of the series, we'll be awarding the entire amount of the credits based on participation. And the hope is that each participant will attend 60 minutes of each of the clinic sessions. It looks like partial credit for attending will not be awarded, so there. And then we'll look on additional CME arrangements if possible. So again, Project ECHO, the whole idea is to create a learning community that's safe, where mistakes where mistakes are welcomed and really are acknowledged as one of the best ways to learn. Nobody knows everything here. Our goal is to create a very safe space to learn together. And there's no, I know it sounds trite, say no question is a stupid question, but really that's the idea here, is coming up with even the simplest questions. Chances are there are many people who are having the same question. We call this 3D ECHO because we're supporting 3 dimensions of healthcare in your community, including the biological, psychological, and social dimensions. So while we're focusing on substance use disorders, we'll always be thinking about all 3, what the biology, the psychology, and the social aspects of each one of these disorders and presentations. Here's a video. I hope it works. Let me click play. Bob, stop me if you guys can't hear it. Here we go.
Yeah, we're not getting any volume.
Can you hear it or no?
Nope.
I can hear it great. So you guys mind if I just listen to it? I'm kidding. So I think there's some weird setting in Zoom where you can do this. Let me see. Does this work? Open speaker autoplay. All right. I won't waste your time.
In your sharing settings, Dr. Arzubi.
It's on sharing settings. Okay.
Yeah,
hang on.
just go share and then share computer audio.
Okay. Let me see.
And I think it should work.
So hang on. So I stopped share. So I'm going to share. I go to application.
There should be a check mark on the bottom for share audio.
Oh, I see. So you know what? This is one. So I think I'm fancy, and I have let me see, video. Well, this is, I think, one of the downsides of using a Chromebook. I don't think it has that option, so I apologize. You should check out the video. It's great. So on YouTube, it's a brief, it's a 1.5 minute video that kind of describes a little bit of the history of Project ECHO. But the idea is just pushing out clinical knowledge, and then creating interactions between the hub and the spokes and across the network, so everybody learns together. That's the idea. So I'm still going to stick with my Chromebook because I like it. All right, here we go. Present. Okay. So it connects groups of community providers with specialists, but again, just emphasizing the fact that everybody out there in the spoke sites have expertise that are worthwhile sharing and teaching. So these are collaborative sessions. We're focused on case-based learning and mentorship when possible. We all teach, we all learn together. And so when you apply all these principles together, you create this learning community in which everybody gets a chance to teach and learn together. So we're going to have interactive elements of this, guided practice, ongoing mentorship, peer-to-peer learning, and then collaborative problem solving. And then one of the things I would also encourage us to think about now remember, this is 3D echo, so we're thinking about all these different dimensions. While we're going to be thinking about certainly the clinical presentations and the psychotherapeutic and biological interventions, let's not forget how important that systems interventions are as well, and understanding systems of care. So some of the cases we discuss, or some of the challenges we might want to talk about together, will involve challenges surrounding the delivery system of healthcare, which, as we know, is part of the solution and part of the problem. The principles of the ECHO model: amplification. So we're using technology to leverage scarce resources. Little known fact, Project ECHO actually has been using Zoom probably for almost 10 years. So it's actually the first place I ever learned about Zoom when Sarah and I went to a training in New Mexico back in 2015. 6 years ago, people were using Zoom. I wish I would have bought stock in the company then. B, share best practices to reduce disparity. So again, while we don't know everything, we do hope that we bring enough expertise to the table that we can help guide best practices. There's certain elements of interventions that can be debated, and certain elements of interventions that cannot be debated. There is science when it comes to any one of the things we'll be talking about: addiction medicine, psychiatry. There's science and best practices, and I hope that if there are discussions or disagreements, that people come equipped with research to back up any positions. And this is, again, our goal is really to come out at the end of this with really best practices, and not practice based on sort of region, because that we know that tends to happen. And so hopefully we can all come together around best practices. Case-based learning to master complexity, and then web-based database to monitor outcomes. So we will be doing our best to collect information from you all about the information you're learning, how useful it is or not, and you'll continue to help guide the quality of what we're doing with you here. So subject matter experts, there's me, Reza Hosseini Gomi, who again, neuropsychiatrist with expertise in neurodegenerative disorders and dementia, and Dr. Bob Seiss, who is our addiction psychiatrist and also board certified in general psychiatry. Program lead is Mary Erickson. Facilitators, we got to meet Amber Rogers, Jessica Listra, and Sarah Porter-Osen, and then Mary Argonis and Sharon Phelps are helping with IT and data support. Who can attend? It's invitation only. No, it's not. You can, anybody's available to attend if they get to the website and want to ask to attend. We encourage primary care providers, nurses, pharmacists, LCSWs, LACs, community health workers, peer support specialists, staff from community-based resources, law enforcement, and students. They're going to be, again, because we'll be touching on all aspects and all dimensions of care, there's going to be a little bit something for everyone. We will talk about clinical cases, recommendations around medication management, therapeutics. So it's going to be something for everyone. And not everybody's going to always maybe understand the nuance behind some of the medication recommendations, but that's okay. I think this is just like learning a language, and the way you learn a language is you listen to it and you practice speaking it. So this is part of the game. Anatomy of an echo session. So really what's different about echo than sort of other webinars is, again, it's much more interactive, and there's a very deliberate structure to it. The very beginning, you start off with introductions. Every time we're going to go through, we're going to kind of check in, see who's here. We don't have to make it as long as we did this time, but I think today was important. Then after the introduction, you have the didactics. And again, we're going to try to keep didactics short. It's not one of these things where we're going to do a 60-minute PowerPoint slide presentation, because those can be painful. We're going to try to keep it short and relevant. And then we want to make sure we have at least one case presentation from folks out there in the region. And that's going to be critical to our learning. So we're definitely going to be prompting you all to come to us with cases. And again, clinical cases are great. If you have other cases that involve maybe a clinical challenge, maybe a workflow challenge at an office, at a clinic, a systems challenge, I guess I invite people to think about any kind of a case that might help everyone learn how to tackle different challenges in clinical as well as system problems. And then at the end, we'll have questions and feedback with participants. And again, our job is to facilitate and at the end, provide a summary and recommendations so everybody walks away with evidence-based guidance. And again, ground rules, is the most important thing is this needs to be a safe place to share. Don't be mean, don't bully your peers, be nice, be supportive, and help lift each other up when it comes to learning. Because the work we do every day is hard enough. So this is supposed to be, again, a safe, supportive, and nurturing place where you walk away, hopefully feeling better and feeling a little bit smarter. And certainly feeling connected, hopefully, right? Also hard to connect with people in a busy day, so feeling connected is going to be critical. Collaboration, we're going to learn from others. You share your knowledge, please. Cameras on. We are looking into technology where we can turn your cameras on automatically, so just beware. No, we're not. I'm kidding, but that would be cool. And then here we go. So I'll pass it on to Bob to talk about the curriculum that he's designed for this clinic. Thanks, everyone.
Excellent. Thank you, Eric. I am attempting to share. If you could stop sharing, Eric, then I can share my screen.
Sure thing. Sorry. Yep.
Excellent. Eric, how's it looking?
You're good.
Excellent. We're very excited to have all of you join us. There's a lot of experience in this group and a lot of diversity in perspective. This is going to be a really rich level of dialogue. To give a quick overview of what we'll be discussing when it comes to the didactic piece of these echo clinics, a summarizing theme, if you will, is we'll be talking about all the core ingredients to identify patients who could benefit from substance use disorder treatment, and really then how to best engage them wherever they may be insofar as their willingness to change and engage in treatment. We'll start off in 2 weeks and fall in a cadence of meeting every first and third Wednesday of each month for the next 5 months for a total of 10 sessions. Starting on the 21st, we'll launch into talking about screening, brief intervention, and referral to treatment. This is the piece that's really going to help us identify patients in need wherever they may be. And it's pertinent really across organizations and different settings. We'll move to talk about treatment, in particular medication-assisted treatment for alcohol use disorder. Similarly, talk about how to engage patients about their cannabis use with a discussion of research. Talk about opioid use disorder and treatment. Also talk about kratom, benzodiazepine abuse, meth abuse, and talk about co-occurring disorders, things like ADHD and psychosis that so often coincide with substance use disorders. And we'll close with a discussion of how to virtually deploy services in treating substance use disorders. I'd like to seize the next 10 minutes to do an epidemiologic overview of pertinent substance use disorders across our regions, talk about recent updates, and discuss the role for MAT as well as psychosocial interventions. It's probably no surprise to those of us who frequently identify and treat substance use disorders, they're all too common. Over 20 million American adults meet diagnostic criteria for substance use disorders, with over 16 million meeting diagnostic criteria for alcohol use disorder and over 6 million with illicit drug use disorders. There's a little overlap. Yet only 7.5% of these Americans get treatment for their substance use disorders. When it comes to opioids, about a quarter of patients who are prescribed opioids for treating the chronic pain end up misusing them. And if we continue to kind of keep a broad scope and think about this overall cohort of patients prescribed opioids, 10% of them will develop opioid use disorder, with 5% transitioning to ultimately abuse heroin. Now, and it's very different in comparison to say 20 or 30 years ago, 80% of current heroin users first abused prescription opioids, making them the gateway to heroin. If we look at the 18-year interval from 99 through 2017, we see that across the country, there was a threefold increase in opioid overdose deaths. Focusing in on Montana, there is an apparent trend that is somewhat reassuring. Specifically, you only see about a twofold increase, with flattening in more recent years. If only this were continued. The latest data reveals, if anything, opioid abuse across the country has escalated, especially thanks to the COVID-19 pandemic and how it's impacted people's stress levels, their likelihood to use substances, and made it harder to access treatment. In a conversation with the former U.S. Attorney for Montana, Kurt Alme, he impressed on me how the latest DEA seizure data reveals there's more and more heroin and diverted opioids here in Montana. Across the country, in the midst of this pandemic, people have been more stressed. We know that depression and anxiety, if anything, increase the likelihood of substance abuse. So it's no surprise that the rates of opioid abuse have increased. Again, it's harder to access care when so much is being diverted into treating COVID. And at the same time, there's not been a lack of access to opioids. Cartels and other purveyors of opioids have remained in business in spite of the pandemic. There are other substances that are commonly abused, and two in particular that we're encountering aren't regulated hardly at all, or in the case of kratom, in most states, it's not regulated whatsoever. Kratom is a botanical from Southeast Asia. At low doses, it has a psychostimulating effect. At higher doses, it behaves like an opioid. In extreme cases, can cause respiratory depression and even death in overdose. Yet it is not controlled by the DEA. And everywhere on this map that is shining green means that it is fully available for recreational use for adults. Even more prevalent, cannabis, in part due to the wave of legalization for recreational purposes across the country, we're seeing more and more use and frank abuse of cannabis. When we refer to the plant cannabis sativa, we are, in the broadest sense, thinking of over 80 separate cannabinoids that have been isolated, but really, insofar as treatment of cannabis use disorder, we're principally concerned with CBD, cannabidiol, as well as THC, which is delta-9 tetra hydrocannabinol. THC is a CB1 receptor agonist. It's psychoactive. It can cause altered mood, the subjective high, impair cognition. In some cases, if people abuse it enough, can lead to worsening anxiety, depression. If they have a primary psychosis, it can worsen the psychotic symptoms. If they have PTSD, it can make that worse too. In contrast, CBD is an indirect cannabinoid 1 and cannabinoid 2 receptor antagonist. It may have immunologic as well as anti-inflammatory effects. It may even be a relatively low potency antipsychotic. The jury's very much out on the beneficial role of CBD, in part because here in the US, cannabis remains a Schedule I substance, and it's very hard to access for research purposes. Yet, in spite of potential benefits from CBD, it's important to recognize that across the board, and the data we have here over the 20-year interval from 95 to 2014, this is all strains of cannabis, be it recreational or medicinal. You can see over these 20 years, a threefold increase in THC concentration, meaning that regardless of how patients are getting their cannabis, they're getting more and more THC, which definitely makes it concerning, especially given it is ever more available to our patients. Here in Montana, it was legalized in the November election, It's not yet available to scale in recreational shops. Sales will begin this coming year. In Alaska, for those of you connecting there, you've seen it is recreationally available. In Hawaii, it's, I believe, only available for medicinal purposes. In Wyoming, it's still illegal. But as we're one country, and in the case of Montana and Wyoming have a shared border, it is quite accessible. Now, over 230 million Americans live in a state where cannabis is somehow legal, be it for recreational or quote unquote medicinal purposes. Over 110 million Americans, that's over a third, live in a state where cannabis is recreationally legal. We've seen a significant increase across virtually all patient populations, in particular youth. And this is really concerning. Simply put, we know that children, adolescents who start using cannabis intensively have way worse outcomes, be it depression, anxiety, and cognitive performance. What we saw from data in Washington, where cannabis was recreationally legalized in 2014, there was significant spillover into the youth population, even though they shouldn't legally have access to cannabis. Some good news is that medication-assisted treatment is available for most common substance use disorders. In the case of opioid use disorder, we can either fully activate mu-opioid receptors with methadone, use a partial mu-opioid receptor agonist, buprenorphine, or use a mu-opioid receptor blocker, naltrexone. For kratom, fortunately, some of the same MAT we use for opioid use disorder is effective, specifically buprenorphine and naltrexone. For alcohol use disorder, by far and away, naltrexone has the strongest evidence supporting its use and helping people cut back and ideally stop drinking. Gabapentin can also be effective, in particular when used with naltrexone. Disulfiram or Antabuse works so long as you can actually get patients to take it. Acamprosate, while we previously thought it was evidence-based, in the most recent studies here in the US, it does not outperform placebo. For cannabis use disorder, gabapentin can help patients, those who in particular are motivated to cut back or stop using cannabis. For stimulants, the data is not as strong. It looks like, based on some recent research, bupropion and long-acting injectable naltrexone may help meth users. There's also some initial data suggesting that long-acting injectable antipsychotics may also help meth abusers. And there is some fairly weak data suggesting disulfiram can help with cocaine use. It's important to note that across these substance use disorders, by far and away, the greatest therapeutic yield, it comes from the psychosocial interventions, with one important exception, that being opioid use disorder. We know opioid use disorder, based on several studies that have been done really since the early 80s, it in many ways is its own beast. It's a separate disease process from other forms of substance use disorder. Think more along the lines of diabetes or schizophrenia, insofar as the mu-opioid receptors, once they get out of whack in opioid use disorder, they don't go back to the way they once were before. To the point that, and it's been duplicated across several studies, if you take a cohort of 100 people that meet diagnostic criteria for opioid use disorder, and they're actively using opioids, you get them detoxed through withdrawal, opioid free, and you follow them for 2 years without access to medication-assisted treatment. But as much as possible, get them in 12-step chemical dependency counseling and all the psychosocial supports you could think of. In that cohort of 100, 95 will see a return to use at some point over that 2-year-long interval. And that is very damning. As we know, folks who go back to use opioids are at risk from overdose. They lose tolerance to opioids and oftentimes go back to using the same dose they were previously using when they were actually physiologically dependent. Fortunately, MAT is very effective. Methadone can be effective. A big obstacle here insofar as making it available to patients is the fact that it's dangerous if people have open access to methadone, as it's a full respiratory depressant. It has to be made available through an opioid treatment program, something that is very much tightly controlled by the DEA. Buprenorphine, the active ingredient in Suboxone in turn, is a partial mu opioid receptor agonist, is quite effective for treating opioid use disorder, and most importantly, is a lot safer. The risk of respiratory depression plateaus at higher doses, and for a lot of people, kind of the ambulatory all-comer patient population, it's virtually impossible to die from a Suboxone overdose, with some caveats. Alternatively, there is naltrexone. Again, it's the opioid receptor blocker, very effective, works generally speaking as well as buprenorphine. The tough part is detoxing people off of opioids and getting them opioid free for at least a week before you can start naltrexone. Still, it's worth emphasizing that for opioid use disorder, full recovery really depends on engagement in 12-step, as well as psychosocial supports, chemical dependency counseling, and motivational interviewing. And again, to really emphasize the synthesizing kind of statement when it comes to treatment, we know MAT in a vacuum does not work, at least not nearly as well as a combined set of psychosocial interventions alongside MAT. So I think we have plenty of time for a case discussion. Do we have any, it'd be a good time to pause for questions or any contributions folks would like to make.
So Bob, this is Eric. I was just going to mention there's some comments in the chat that kratom is something that hadn't been that people hadn't been familiar with until you mentioned it. So I don't know if is that something kind of when did it kind of hit the radar in addiction medicine?
Yeah, so it's certainly been around for the last 4, potentially 5 to 6 years. There was big talk back in late 2018 about scheduling it, putting it on one of the DEA schedules, because again, there's a potential for overdose. And we know from a physiologic perspective, it behaves enough like opioids that you get physiologic dependence, and people will escalate the dose. So while they may start using it recreationally, and especially at lower doses, maybe see a slight benefit from using a psychostimulant, a super coffee of sorts, as the dose creeps up, people can come to the point where they're using 5-6 grams a day or more. It's costly when they're using that high of a dose, and they run to the risk of respiratory depression, in particular when they're combining with other things like alcohol, benzos, barbiturates, or opioids. Fortunately, I'm seeing, I just Googled it and it's listed on some of our pot shop websites. Yeah, Dorothy would just validate that it is wild how easily people can get kratom. If you were to, fortunately, I can't really do the side by side of those two maps where kratom is fully legal versus cannabis. You'll see kratom is available for all-comer adults, no need for any sort of prescription, way more available across the nation than cannabis. And yet, arguably, when it comes to the health effects and the risks associated with use, is way more worrisome than cannabis.
Bob, I'm sorry. Do you mind just unsharing your screen just so we can?
Yeah.
Sorry about that. No worries. No worries. The other question, Hope had asked, do you actually, before I turn to Hope, I think Agnes, did you have your hand raised?
Yes.
Sorry, go ahead.
Can you hear me? Am I unmuted?
Yes.
Oh, I was just wondering about opioids. The medications to treat them, to treat the addiction, are people on this for life, or they can they eventually get off the treatment and the medications?
And that's a great question, and it's something that comes up a lot in policy discussions. Again, if we look at the data, we know opioid use disorder is a lot more like diabetes than it is other forms of substance use disorder. And I think the diabetes model pertains in that, think about diabetes. When someone gets diagnosed, in particular with type 2 diabetes, how many people in a cohort of 100 that get diagnosed with type 2 diabetes are able through diet and exercise to reverse the disease process? Very few. arguably under 5%. Same goes for opioid use disorder. And we don't know if there is some sort of genetic vulnerability in folks who develop opioid use disorder, predisposing them that once activated sets them up so they can't go back on that pathway. Suffice it to say, if you look at the data, the fact that people who are treated with opioids in a longstanding way, a quarter end up abusing them and 10% end up with meeting diagnostic criteria for opioid use disorder, it's pretty damning. And we know for a fact from the perspective of physiologic dependence, meaning your body changes its equilibrium because you're using a substance on a daily basis. We know it only takes 5 weeks to develop physiologic dependence on opioids. So this is a really powerful substance that for all too many years was too widely available. And now, especially here in the US, where we consume half of the opioids in the world and have what, like max 5-6% of the world's population, we're really now in payback mode. And treating this disease process with the latest evidence really indicates people need indefinite treatment. And for some, that could be IM naltrexone, which tends to be the lowest risk and quite effective.
Thank you.
Thanks, Bob. There's another question. There are a couple other questions there. One is, do some people self-treat with kratom to alleviate pain or addiction?
Yeah, yes, they do. You'll run into people who thought of it, especially up until the last year or so, thought of it as a free lunch on treatment of pain. It activates mu-opioid receptors, and anything that does that, be it kratom, tramadol, morphine, you're going to see some pain relief. It's analgesic. The problem is all too often they end up escalating the dose and they become fully dependent on it.
Got it, thanks. And then the other question was, can kratom be detected in drug tests for opioids? Or is there cross-reactivity, I guess?
Yeah, so not on the qualitative assay. When we think about urine drug screens, there's the qualitative, which is kind of like a all or nothing, yes, no. Probably the most common one, it's the cheapest. It also tends to be the least sensitive and specific. Then we also have a quantitative urine drug screen that will actually give levels of substance. We can get it on there, but on most kind of the all-comer quick check ED urine drug screens, you're not going to see kratom.
Thank you.
And I want to make sure we're doing right by all the questions. It's a great group. People are jumping in.
Other comments, clarifying questions? So I guess I just have one question out there because we have people from different regions. What is it difficult? So what's more challenging right now? I guess I'm curious for the group is what's more challenging? Is it more challenging to actually find someone who does medication-assisted treatment, or is it more difficult to combat sort of maybe myths surrounding the treatment of opioid use disorder? In other words, or in some places it's hard to access because sometimes people are reluctant to actually provide this type of service, or is it just because there's just lack of providers, or is it kind of a combination? I'm just curious because I think every region, every community is a little bit different. People have thoughts.
And just to elaborate off that, kind of the concrete question that comes up, and I saw a lot here in Billings, is are there many X-waivered providers? So we're thinking about physicians, nurse practitioners, or PAs who have a special DEA sublicense to prescribe Suboxone. Is there scarcity of that? And then if there isn't, is it still hard to find someone to prescribe? Because sometimes, even though people have those waivers, they're not willing to prescribe. Just thinking of kind of a concrete question.
We're not beyond picking on someone, just saying. Okay.
Dorothy, would we be able to ask you to speak to that? That's great. You're mentioning that given the extent of substance use disorders in your state, accessing an adequate number of providers is an issue. Would you be able to tell us a little bit more?
Yeah, so the largest part of our population, about probably 350,000, live in the Anchorage area. And there is plenty of access to providers here in Anchorage. However, the majority of the state lives outside of Anchorage, and a lot of them are off the road system. So having access to providers that are not only willing to, but knowledgeable about treating substance use disorders is limited at best. And I mentioned that I work for also Department of Corrections. It's amazing how many folks in jail have severe substance use disorders. And there's a limited number of providers that will be accessible to that population.
Thank you. That's really compelling.
I had a quick question. Sorry, there are a couple of questions popping up. I just curious, Tamara, given the work that you've done statewide in this area, I'm just curious, what's your take in Montana? Is it, or because like Bob was saying, there are a growing number of people with X waivers, but how many people are actually using it? Either because because the provider is risk averse and is nervous about working with that population, or lack of buy-in from patients for whatever reason. I'm just curious.
Yeah, we've got, in 2017, I think we had 22 waived providers in Montana, and now we're up to something like 182. Our focus in the training, the focus was statewide, get everybody and anybody trained. Everyone was welcome, and there was no charge on CMEs, so it doesn't get much better than that. Our data that we have collected is focused primarily on the FQs, and we've got within the FQs, we've got about 54 providers that are active in using their waivers. There's only about, gosh, if I remember right, about 9 providers who are not currently using their waivers. And the primary reason for that is time, and especially, during the last year with COVID. So time, and then kind of a felt sense of a lack of IBH team support. So we really promote and train on, with program implementation, the team approach. And, like you were saying, Matt doesn't stand alone. The motto that I borrowed from DBT is, skills and maybe one pill. DBT says skills, not pills. I couldn't be more in agreement that you've got to have skills, a way to change skills, or to develop skills to achieve abstinence. One of the what would you call it? Kind of a, there's a kind of a crash that comes with, okay, do we do behavioral health or don't we do behavioral health? Do we force patients to go? Is that going to be conditional on their receiving, medications for opioid use disorder? It's an ongoing discussion. And of course, when MAT first came out, there was a lot of rigidity in the programs that were offered, at least here in Montana. And ours being one of them, it was, you get behavioral health services or you don't get your prescription, the end. But we have transitioned, I know, I'm not sure if we're going to go into full detail on this at some point, but it's transitioned into the harm reduction model because there are so many deaths. So anyway, to answer your question, resistance to using the waiver is time, and not as much behavioral health support or team support as they would like to have in place.
Thank you.
Yeah.
And there's another question, Bob. So I wonder if some of these maybe.
Yeah, we can definitely, for example, physiology of addiction. We'll definitely spend some time in several of the focus didactics on the distinct substance use disorders to address that. See a question about gabapentin. Gabapentin can be abused. People will on occasion use it to potentiate the opioid high. It is way safer than benzodiazepines, and remarkably, in the case of alcohol use disorder, especially when people are coming off of alcohol, can decrease their relative GABA deficit. And what that's basically a medical term to say it will decrease their need for benzodiazepines. So is a way safer way to treat people, especially when they're coming off of alcohol. And data shows that it can help them decrease their alcohol use when used in combination with naltrexone.
So again, what you're saying, Bob, it sounds like it's, and I think you've taught me this along the way, and when our work together is, it's just, again, harm reduction. You either have gabapentin or you're going to have alcohol, benzos, and the other stuff. At least this way, you can collaborate with the patient and do it together.
I think it rings true on harm reduction. Also rings true on evidence-based medicine.
Correct.
If you look to really the most effective treatment, especially for people who are committed to abstinence, they're still going to have some degree of cravings, and we know alcohol withdrawal doesn't just last the first 72 hours. More, it's 2 to even 3 weeks out from the last drink. And gabapentin can help with some of the anxiety and sleep disturbance that takes place through that prolonged, more subtle alcohol withdrawal.
That's great. And yeah, and even though it's an N of 1, there was one patient that you and I talked about and you helped me with, who was it was a young adult female struggling with both cannabis and alcohol use disorder, and gabapentin was incredibly useful actually over the course of 4 to 8 weeks. Actually was able to reduce the amount of use for both alcohol and cannabis. So again, it's an N of 1. It doesn't generalize to everybody, but I've seen it, and it's pretty cool. Cool. So I think we're here. It's 3:56 p.m. There's a survey, so it'd be great if everyone could just click there and give us your feedback on today's session. Bob, thanks a lot for leading the didactic and leading the discussion, and thank you everyone for participating and leaving your cameras on. That's super helpful, and it's really more engaging. So thank you for that. Is there anything else that I need to bring up? Anybody from our team, our hub, or out in our spoke sites? No. Good. Amber, do you want to wrap us up? You started us off, so I think you deserve to wrap us up.
Well, I just want to thank everybody for attending, and feel free to share this email to the email series to your cohorts, your friends, your fellow nurses, your social workers that work with patients. And I hope we can continue this community learning. Thanks, everybody.
Thanks, everyone.
Thanks, everyone.
Take care.
Bye.